Well, good morning. So what I want to talk to you about, no, that's fine, thank you, is we were sitting around with the residents and we were talking about how do you intubate someone with high pulmonary pressures. And one resident just put her hand up and said, just put them on ECMO. And if there was a mic, she would have dropped it and walked away, and that was it. And Zach, in all honesty, I will say something kind about Zach, unlike him. He's a hero in emergency medicine. I mean, what he's doing out there is revolutionary and will change the way we practice medicine in 15 years. But you can't put every patient on ECMO. There are so few centers that do that, so there are other things that we can do. You've heard that patients with high pulmonary pressures and RV failure are high-risk intubations. Some people say the mortality is somewhere like 100%. 100% mortality if you have to intubate somebody, but there are patients that you have to intubate. Is the mortality really that high? And where do we get this concept of 100% mortality? Well, it's about this, the RV death spiral. Has anyone ever heard this before? Well, I want to introduce it to you and go through why patients who we intubate with high pulmonary pressures can eventually lead to cardiac arrest and die. When you put someone on positive pressure ventilation, you're increasing the pulmonary vascular resistance, which means you're increasing the RV afterload. That means that RV has pushed really, really hard against the tight resistance and can't get blood over to the left ventricle. The RV also dilates as a result, and that results in less coronary filling. The RV fills the coronaries in the RV filled during diastole and systole, unlike the LV. So that reduces the coronary filling, and that means you get RV ischemia. That RV ischemia leads to a reduction in the contractility of the right ventricle. So now you have an RV that isn't working as well. That means there's less cardiac output out of that right ventricle. And the right ventricle, the only reason why it's there is to fill the left ventricle. And if you're not filling the left ventricle, you're reducing your preload, you're reducing your cardiac output, and that results in a reduction in your mean arterial blood pressure that comes out of that LV. What does that mean? Well, now you have a reduction in your coronary perfusion overall. So now decreased cardiac output, reduced coronary perfusion, this leads to more cardiac ischemia. More cardiac ischemia to the RV and the LV this time, and now you have cardiogenic shock. And the end result of this entire death spiral, if you will, is death in your patients. So all the way from the first positive pressure breath that you gave your patient, causing pulmonary arterial vasoconstriction, causes a chain reaction all the way down the line that leads to cardiogenic shock and the risk of your patient dying. So how are we going to take care of these people? Like I said, you're going to have to intubate some people with severe pulmonary hypertension. So what's going to be your approach? Well, I think about the approach in really two big boxes that you have to pay attention to before you push any drugs, before you bag your patient. And the two big boxes are this. You're going to have to optimize the performance of the right ventricle, and in small parentheses, improve the performance across the pulmonary vascular bed, and you have to minimize the amount of hypotension that patient develops. So let's go ahead and talk about the right ventricle first. What can we do as we're preparing and during intubation to make sure that RV is pumping well? The first thing we want to do is optimize preload. Now, the RV does not like lots and lots of volume, so you don't want to give them 2, 3, 4 liters when they're hypotensive. You want to give small aliquots of 250, 500 at a time. If their blood pressure gets better, great. If their blood pressure doesn't get better, don't give them any more volume because the RV will just dilate, and you already saw what happens when the RV dilates. It's no good. The next thing we want to do is to increase inotropy of that RV. And how do we do that? You can pick your inotropic du jour. You can do dobutamine, you can do low-dose epinephrine, you can do even milrinone if you feel comfortable with it. But whatever you do, get that drug started before you enter the active intubation because everything that you do is going to put you in that death spiral. Stay out of that spiral, give them inotropes. Open up their pulmonary arterial vascular resistance by giving them vasodilators. Okay? What drugs do you use? You can use inhaled nitric oxide, you can use inhaled epoprostenol, whatever it is, vasodilate so that blood can get from the RV over to the LV and keep those coronaries perfusing. Pay close attention to your oxygenation and your ventilation because if your patient gets hypoxemic, they drop their SAT, they're going to get pulmonary artery vasoconstriction. This is working against you. Give them 15 liters high-flow nasal oxygen and face mask. Make sure you really bump them up with their oxygen. And make sure you don't get too far behind with your ventilation. Don't let them get too acidotic. Acidosis will also cause pulmonary arterial vasoconstriction. So those are the things that you're going to do to make sure that your RV stays at the top of its game, and then you vasodilate the pulmonary arterial vasculature. Let's talk about minimizing hypotension during your intubation. The first thing you should do is be cognizant when you're drawing up your drugs that you want to use smaller doses of your sedative hypnotics. Okay? Whether it's ketamine, etomidate, whatever it is, draw smaller doses because those drugs will lead to hypotension. Paralytics, go full dose. You want to have optimum intubating conditions, but smaller doses on your sedative hypnotics. The next thing we want to do is get vasopressors ready. Whether you're a fan of push-dose pressors or not, if you are, then draw up your epinephrine, get it ready to go. If the person drops their blood pressure, then give it to them. If you're not a fan of push-dose pressors, then get your norepinephrine primed, ready to go in the pump. And if the person's already having a soft MAP, bring their MAP higher before you enter intubation. And if they drop their MAP, rescue them by increasing their blood pressure. If you have the time, the ability in your ED, the luxury of having an arterial line, definitely want to have it in before you start intubating, because I want to know the moment that person drops their blood pressure, not 10 minutes later when the cuff cycles and I'm like, oh crap, this person's been hypotensive now for a few minutes. Get an arterial line in if you have the ability to do so. And the very last thing is be aware of the settings that you put on your ventilator. Remember, the ventilator is going to work against you. It's going to cause pulmonary artery vasoconstriction just by the sheer fact of positive pressure ventilation. That's going to increase the RV afterload. But be careful not to let that person get hypoxemic. Just give them lots of oxygenation. Be sure that you ventilate them appropriately. Don't let them get hypercarbic and acidosis. That will also work against you. If you go into the intubation optimizing the RV and minimizing hypotension, you may not have a 0% mortality in your patients, but you certainly decrease your risk of your patients dying on you during intubation. Thank you so much for your attention.